So we enter into special testing of the knee. And just like with our systematic ordering of testing or going into palpation, then range of motion, and finally manual muscle testing, special testing is our last stop. It's by far my most favorite part of a clinical evaluation because it's what we wake up to do, to figure out what is wrong with our patients. And our special testing will allow us to do that in the clinical setting. Within the knee in particular, one of the concerns with injuries to the knee joint, the tibial-femoral joint, is the idea that swelling can hide within the actual joint capsule. So a patient could be walking around with an injury and you wouldn't be able to see that swelling. That swelling is called intercapsular swelling or effusion. And so the first stop in special testing is always with a swelling or effusion special test. So there are 3 swelling or effusion special tests within the tibial femoral joint. The first one is the sweep test. And I'm sure we've all swept something at some point in our life. Just think of the sweep test as a sweeping test. We're going to start most distal on the femur, and then on the tibia more proximally. And you'll see my hands just lying here in a flat-handed kind of position. What we're going to do is we're going to sweep any fluid that might exist both proximally and distally and move it to a centralized location. On the lateral side, you're not going to see this very well. We're going to push that swelling medially. And what we're going to do is basically just take our finger and press right here within this pouch. And what you'll see in a positive knee joint is there will be like a pouch of swelling right here on the medial aspect of the knee. So a positive test would be one in which we sweep all the fluid, milk it all medially, and press here, and we can't either feel that femur or the medial facet of the patella. Okay, guys? The next special test that we're going to go into is the ballotable patella. And I like explaining this to students because I equate it to like a rubber ducky in a bathtub. And I'm sure you all had a rubber ducky. If not, we'll do it in lab so you can see what I'm talking about. But here's kind of how I remember this test. Think of a rubber ducky. You put it in the bathtub. When a kid bounces around in the bathtub, what does that rubber ducky do? It bounces with the waves, right? And the flow of the water. So ballotable patella is similar. Just think of the patella as a rubber ducky in a bathtub. Our hand positioning is going to be the same as it was for the sweep test, right? The next thing that we're going to do is, like we did, is milk all of the swelling centrally. But this time, instead of our finger going here like with the sweep test, what we're going to do is apply a downward pressure on that patella, right? And if there's intracapsular swelling, what you'll see, like you see with a rubber ducky in a bathtub, is that patella will bob up and down. What you won't feel is the patella make contact with the femur, which it should do. It can't do that because there's so much swelling. So a positive ballotable patella test would be one in which that patella continues to bounce or bob up and down, okay? Last but not least is the bounce home test. For the bounce home test, the patient has to be in a different position. So in terms of patient positioning, the patient's going to be supine, and it's a movement test. So what we're going to do is position ourselves in such a way that our body is towards the foot of the patient. So I'm going to get in that position now. And so if I'm the clinician, my position on the patient is here. Okay, and so the next thing that I'm going to do is I'm going to pick up the patient's leg and put it right on my hip, okay? It's gonna sit right on my hip here, and then the next thing that I'm going to do is grab the proximal heads of the gastroc. So you kind of can't see that. I'll lift it up so you can see it just a tad bit. Okay, so I'm here, I'm cupping here, I'm cupping there, and then what you'll see with the patient's foot is it's supported. So if I let go of the patient's limb, I've got it supported with my elbow. Does that make sense, guys? Okay, so hands, elbow here holding the patient's foot, hands just over the gastroc heads proximally, and then my fingers just rest on the tibial tuberosity. The focus of this test, as the name implies, it's a bounce home test, right? So we're bouncing something home. Well, in the knee, what's home base? It's knee extension. So a bounce home test is us bouncing the knee from a flexed position to an extended position, okay? So I'm going to essentially end up doing something that looks like this. You ready? They're here in flexion, and I'm gonna allow that knee to drop into extension. I'm gonna allow that knee to drop into extension. And do you see how when it drops home or drops into extension, that it stays there, right? In a patient who has an intracapsular swelling, That won't happen. What you'll see is, I'll recreate it for you. It'll do this. It'll bounce right back up, right? Why? Because there's so much swelling in the capsule that it can't bounce into its home or extended position and stay there. It won't allow the tibia and femoral condyles to get into the resting position. So a positive test would be one in which we bring it here, we let it drop, and it doesn't stay in extension. It bounces back up into a little bit of knee flexion, okay? So we have 3 kind of clinical tests that we can use with our hands to assess a patient swelling. And then the other one that we can use is what's called girth measurements. And so we'll show you that in lab. But essentially what we do is we take a measuring tape, and now we're actually going to get a physical measurement of the size of the knee and compare that side by side. So that concludes special testing for our swelling, and now we'll actually move into special testing for pathologies. So now that we've tested for swelling, what we're going to assess now is instability of the knee, because the reality is most injuries that happen to the knee cause some type of instability. That instability could be medial instability, could be lateral instability, could be posterior instability, it could be anterior instability, or the worst kind of instability is a multi-directional instability. So in this next segment, we're going to talk about the different types of instabilities and what they would be testing. The first assessment for instability that we're going to do is a medial instability test. This test is going to assess the stability of the medial or tibial collateral ligament. And so with that said, remember that is a medial structure, right? Therefore, in order to test a medial structure, we have to apply a lateral force to that structure. So right now what we're getting ready to do is what is called the valgus stress test. That valgus stress test is a test for medial instability. A few things are important about the valgus stress test. The first thing is you're going to grab the patient's limb, okay? You're gonna grab that patient's limb and you're gonna put that right at about your iliac crest, okay? Then I'm going to, just as I did with the bounce home test, I'm going to use my elbow to hold that patient's limb against my hip, right? And that's just more of a stability thing for the patient. The next thing that I'm going to do, just like I did with my bounce home test, is grab the popliteal fossa, I guess is the best way to say that. What I'm going to do is apply a valgus force. Now, what is a valgus force? A valgus force is one in which the force is being applied from the lateral side of the knee to the medial side with the goal of stretching that ligament, okay? So if I want to apply a valgus force, what I'm saying is that valgus force is going to stress my MCL or medial collateral ligament. So if that's the case, I'm going to grab the patient's knee, and with the knee extended and at 0, I'm going to apply a lateral force. So my force is in this direction. Make sense? Might not see it because she's not injured, but this is the force that you are applying. Do you see that medial side of the knee opening up? Okay. Now we are going to do this test at 0 degrees of extension, right here, which will get joint capsule, right? So whether or not the capsule's actually injured, and then we're going to flex that knee to about 15 to 30 degrees of knee flexion, and we're going to do the same test. And you can see it looks like our patient actually has an MCL injury. Can you see the looseness? The way that knee opens up right there. Focus right there. Do you see it? Okay. Now, if at 30 this is positive, right, then we know that that patient has a ligamentous tear. So if we're at 0 and it's positive for pain or laxity, the capsule is damaged. If we're at 15 or 30 and it's positive for laxity or looseness, then we know that the actual medial collateral ligament is damaged. Okay. So for review, prop that patient's foot up on your hip. Use your 2 hands to create a medially directed force on the lateral side. If at 0 you see opening of the joint capsule, that's a joint capsule sprain. If at 15 or 30 you feel opening of that joint capsule, that is an MCL sprain. Okay? Now, its sister or brother ligament on the lateral side is the LCL. So the opposite's going to apply. If we want to test for lateral instability, we're testing the lateral collateral ligament. That test is known as a varus stress test. I'm going to shift and test the opposite leg, okay, of my patient. So positioning, the limb goes up on the pelvis, okay? And now, same positioning, but now my force is moving from a medial side to a lateral force, okay? So hands are here. At 0, I'm going to apply a varus force to the lateral knee, okay? Varus force. If there's opening up at 0 degrees, then we think joint capsule. If there's opening up at 15 to 30 degrees for varus force, then you're thinking an LCL injury. And I don't know if you guys can see it, but right there, look. See that joint opening up? So we know that we have a lateral or fibular collateral ligamentous injury, okay? Probably grade 2. So what's a positive, you guys? A positive would be one in which, guess what? There's looseness, there's opening up of the joint, okay? With each of these ligamentous tests, we have to focus on one thing because it is super tempting to focus on pain with these exams. When we are talking about instability ligamentous testing, our number one question is always going to be whether or not you feel laxity. I hope that makes sense. Okay, guys? Laxity is our gauge. Now we're moving to the posterior drawer test. So the posterior drawer test is a test for posterior instability, right? When we're thinking posterior instability, what we're thinking is we're testing the posterior cruciate ligament of the knee. So the next 6 tests that we will do will all be to test whether or not the posterior cruciate ligament has been compromised. The most common test that we've seen done in the clinical setting is the posterior drawer test. And so with the posterior drawer test, the patient is still in a supine position just like they were for that MCL and LCL. The major difference is the positioning of the limb. So for the PCL, what we're going to do is have our patient flex their knee. Now, the ideal situation would be one in which the patient's knee is flexed to 90, right? And their hip is flexed to about 45 degrees, give or take, okay? So with that said, what happens is the clinician is actually going to sit on the patient's foot. Now, this is that awkward moment in a clinician-patient relationship where you're like, oh, this is weird. Foot on my butt? No. So one thing that I typically do with my patients is say, hey, I'm getting ready to sit on you and my butt will touch your foot. Are you comfortable with that? So I'm getting patient just consent because I've had patients say absolutely not, no way. And if that's the case, you're gonna have to have someone come hold and stabilize that foot for you, okay? So as the name implies, it's a posterior drawer test. So I'm gonna sit on this patient, and since my goal is to test the posterior cruciate ligament, I am going to push the tibia posteriorly, okay? So what I'm gonna do with my 2 hands is place them on each side of the tibia, okay? Not lower tibia. You need to be right on that proximal tibia. And I would use my tibial tuberosity as a really good gauge of where hand placement should be. I'm going to hug. Now by hug, I do not mean grip. I'm going to hug, right, those gastrocs. So with my hands on the gastrocs and my thenar MNI, see that right here? Right on the tibial plateaus, I'm going to apply a posterior force. Now, listen to me. Posterior force. Make sense? Say it again. Posterior force, right? So just like with any instability test, what we are looking for is for that tibia to shift posteriorly, right? In an ideal world, what we would say is we don't want that tibia to shift posterior, right? We want it to stay in its place. And if it does shift posterior, then we're concerned that that patient has ruptured their PCL. Now, a few things that young clinicians tend to do is they'll get in there and they'll do this. With this test, you want to really make sure that it's a slow push posteriorly, right? Because if not, you guys, if it's not a slow push, one of the concerns would be if it is actually ruptured and you push forcefully and fast, guess what? You're going to maybe make the injury worse. So in terms of posterior instability test, the number one positive sign that we are looking for is posterior laxity. The laxity that happens as I push that tibia posteriorly, okay? Our next test on the list is a posterior Lachman's. Certainly not my favorite clinical test because of the awkwardness of the position of the clinician, but certainly has better clinical specificity and should be used whenever you are testing for a PCL injury. So a patient is still going to be in a very supine position, right? Patient's still in a supine position. But instead of the knee being flexed to 90, knee position and hip position change. The hip position is now more neutral, and the knee position is about 20 to 30 degrees of knee flexion. So you can already see right away 2 different knee positions for 2 different posterior instability tests, okay? This is the posterior Lachman, so it's gonna look a little bit different. In addition to the knee being at 20 to 30 degrees, the other thing that we have to do is make sure that that tibia is externally rotated, okay? So we've got knee at 20 to 30 degrees of flexion. We have the tibia externally rotated, if that makes sense. Now, proximally, my hand is going to be just here, gripping the quadriceps muscle. And then distally, my hand is going to be right over the tibial flare, right? And you guys can imagine what I'm going to do in this clinical scenario, right? I'm going to push that tibia posteriorly. I am doing nothing with this hand here. The only thing this hand does is it stabilizes. So imagine this. I'm here stabilizing that, and then I'm going to apply a posterior glide. So remember, imagine movement going posteriorly. I'm going to apply a posterior glide to see if I get any posterior translation. And it's really just that simple, guys, all right? So listen to me. With a posterior Lachman's, the difference is the hip is going to be in a neutral position. The knee is going to be flexed to about 20 to 30 degrees, and that tibia is going to be externally rotated. The way or the direction that we push the tibia is still the same, right? It's still posterior. What we're looking for is also the same. We're looking to see if there is actually an increased amount of posterior translation, which would again be indicative of a posterior cruciate ligament sprain, okay? The next test that we're going to move to is one that's more passive in nature, probably one that's more gravity dependent in nature, and that's the posterior sag test. The posterior sag test is one in which the patient is going to be lying in a supine position like here. The hip's going to be at about 45 degrees. The knees are going to be at about 90 degrees here, right? And the big key component is you want to make sure that the sole of the foot is actually making contact with the table. And so I'm going to push the patient back just a little tiny bit. So we've got all of these things happening. Hip at neutral, or maybe 45 degrees, sorry. Knee flexed to 95 degrees. Making sure that the patient's foot is in contact with the table. And then all we're doing in this particular test is, number one, observing where the tibial plateaus lie in relation to one another. Does that make sense? So that's number one. Where are the tibial plateaus? Are they even? Is one more posterior, as is the case here? So is one sitting more posterior or backwards than another? Does that make sense, guys? And then last but not least, once we've observed that, the next thing that we want to do is listen to me, tell the patients to contract their quads while keeping everything stationary. So go ahead and contract. What you will see when they actively contract their quadriceps, if they have a PCL sprain, is when they contract, go ahead and contract again, it will pull the tibia posteriorly and you will see the tibial plateau shift. You'll see that shift posteriorly, okay? So a positive would be one in which, number one, you're looking at tibial plateaus and maybe they're unequal. So maybe this one's sitting posterior. But then the other thing that happens is when they actively contract, go ahead and contract, you'll see that during the quadriceps contraction, right, what you will see is the tibia progress or move posteriorly. So that would be a positive, okay? That's posterior sag. Godfrey's 90-90 is a more clinician-based test. So what you're going to do is place the patient's hips at 90 degrees. patient's knees are going to be flexed to 90 degrees, right? And what you are going to do is essentially what you see here, right? My arms are now supporting the tibias of my patient, okay? And this becomes instrumentally important. The other thing that I always do for my patient is I'll say, hey patient, can you just completely relax and let your legs fall into my arms? And the reason we want this is because if they're actively contracted, you're not going to see what you should be seeing in this test. So with this test, it's a gravity dependent test, right? In essence, once we place the patient's legs up at 90 degrees, once we tell them to relax, what's gonna happen if there is a PCL rupture is that gravity will force the tibia posteriorly. There's no contraction happening. Gravity will force it posteriorly. Does that make sense? So what we're looking for is, as we're looking over here, do we see one tibia sitting lower than another? Does that make sense? That's all gravity. It has nothing to do with the patient whatsoever. Key things to keep in mind with this Godfrey 90-90 test is making sure the patient is 100% relaxed. Okay, guys? All right, let's go ahead and do one final posterior instability test. That is going to be the reversed pivot shift test, or as some know it, the Jacobs test. And you'll learn in this class that most of these tests, if they actually have names associated with them, are named after the physician, the physical therapist, or the clinician who actually identified this as a test. Does that make sense? Okay, so the reverse Jacob test, the patient is still in a supine position, okay? Most often the test knee, so we'll put this knee down, the test knee is going to be at about 40 degrees of knee flexion. And if I'm the clinician, I'm going to be on the same side of the injured knee. Does that make sense, guys? I hope so. Okay, so what we're going to do essentially with this particular test is, number one, what we're going to do is just look at the landscape of the knee. Does it look normal? Are we already starting with a posterior sag? What things are we seeing on the knee or on the knee that's injured that is being tested, okay? Once we get there, one thing that we want to do is we take our, distal hand and place it on the medial longitudinal arch. And this is all in your note packet, so please have your note packet out as you're going along with me, okay? The other thing that you want to do is you're going to flex the knee here. Makes sense so far? We're going to externally rotate the tibia, apply a valgus force. Does everybody see that? So listen, I've got my hand, the top hand, okay, the one towards the head, on the lateral side of the knee, kind of at joint line level. I have my distal hand in the medial longitudinal arch, and with this distal hand, I am externally rotating that knee. So I want the tibia to be in external rotation. I want my top hand or hand towards the head to be in the joint line, and here's what we're going to do. All in one motion, with the foot externally rotated, and valgus force being applied, we're going to bring that knee down into an extended position, okay? And what should you feel when you're doing that maneuver? What you're going to feel is the tibial plateau. It's going to sublux or clunk as that knee moves from that flexed position to an extended position, okay? And if you feel that, then what we know is that patient has a ruptured posterior cruciate ligament. So I'll repeat one more time because I know I talk fast, okay? So distal hand in the medial longitudinal arch, its major role is to externally rotate the tibia. Bring that limb up into flexion with our hand that's closest to the head. We're going to apply a valgus force while externally rotating. Right about here, what you'll see is a clunking of the tibia, okay, or a subluxing, and you're going to bring it back down and it should clunk back into place. If that is positive, if you get a positive clunk, if you feel a shift, most often they probably have a ruptured PCL. Now, these tests are listed in a specific order for a specific reason. This reverse pivot shift test is by far the most intrusive. It's the one that's going to replicate probably the injury, so it's why it's listed last. So what am I saying to you? This isn't the test you start out with if you think they have a PCL rupture, because the clunking will make them apprehensive for anything moving forward. So start with your very basic posterior drawer and your posterior sag, your Godfreys, maybe even your posterior Lachmans, and then progress into a more intrusive, invasive test such as the reverse pivot shift. I believe that concludes all of your posterior instability tests. So moving into the anterior instability test, probably the group of tests that you'll use most often in the clinical setting, most certainly. There are three special tests that I'm going to show you in this class. Certainly are more, but these are the top three clinical tests that orthopedic surgeons use to assess and rule out an anterior cruciate ligament sprain, and I've listed them in the order in which they should be done. The first one is the Lully's test. The Lully's test is relatively new to the field of athletic training. Probably within the last 2 or 3 years, it's gotten the most notoriety. And so it is the test that is recommended by all orthopedic surgeons in the field of athletic training. So with the Lully's test, the patient is going to be in a supine position, so go ahead and lay down in a supine position. And a few things are going to happen here. The first thing that you're going to do is take your proximal hand, or the hand that is closest to the patient, and essentially it's going to be the force that you're using to apply the downward force. And then you're going to take your distal hand, or the hand that's closest to the feet, and you're going to place that in the middle of your patient's calf like a fist. Does that make sense, you guys? I'm sure you can see that pretty good. Right? And we're going to do this bilaterally, of course, but on the injured side, this is what it's going to look like. Remember that hand that's going towards the head is going to go like right in the middle of the quads, and what you're going to do is apply a downward force with this hand. So it's here. And what you'll see happening, right? Do you guys see it happening? Is as I apply a downward force, what's happening here at this patient's heel? Ready? You guys answer it for me. I'm hoping that you're saying the heel is moving or moving upwardly, right? If we have a patient with a ruptured ACL, an ACL that's not intact, the heel won't move at all. So a positive would be no movement of the heel when there's a downward force, like we see here. That is a Lully's test. Again, going to be testing for anterior cruciate ligament rupture. Our next test is going to be the anterior drawer test. It is probably the worst clinical test to use in the clinical setting because it's really not good at ruling in or ruling out an ACL injury, but certainly is one that we've used for years and years and years, and you will be testing on it, so I'll show it to you anyways. But just like its sister or brother test, the posterior drawer test, this is an anterior drawer test. So its goal or job is to test the integrity of the anterior cruciate ligament. So we're going to be doing the opposite of what we did in a posterior drawer test. Still going to sit on our patient's foot. Okay, patient, can I sit on your foot? Mm-hmm. And then what you're going to do, which is different, is you're actually going to put your hands on the posterior aspect of the knee, right in the popliteal fossa, and now that pull, instead of being posterior, that pull is now going to be anterior, okay? Now, if you can look at your patient's knee, what you're really going to be looking at is that tibial plateau, and what you want to look for as you're pulling anterior is whether or not that tibia is moving forward, and how much forward that tibia moves in relation to the uninjured side. So we're always comparing it to its other side, okay? Things that we don't want to do, right? We want this to be a very slow test. The way that I equate this is, the way that I remember this and the way that I remember how slow to pull is just to think about pulling out a drawer in a dresser, right? If you go to your dresser and you pull out your dresser drawer, you're not going to pull that dresser drawer out quickly, right? Because what might happen? It'll fall on the floor. You pull that out slowly and you pull it with caution. So when you're doing your drawer test, the same thing applies. You want to pull slowly so that, number one, you don't injure your patient, but number two, we don't have muscular contractions as a result of the quickness of the pull. So be very slow. The next and last test for anterior instability is going to be an anterior Lachman's test. It seems like posterior and anterior have The same test, but just in different directions. So with that said, the patient's going to be supine just like our patient is here. We're going to take that knee from a 90-degree angle to about a 20 to 30-degree knee flexion angle here. And again, that tibia is going to be slightly externally rotated. In terms of hand position, a few things need to happen. The first one is, again, just like with that posterior Lachman's, one hand's going to be about a little bit distal on the quadriceps. The distal hand is going to go over the tibial flare. And so this is my position as I get ready to test the ACL, okay? Now, the major difference between a posterior Lachman's and an anterior Lachman's is the direction of pull, right, guys? So in this particular case, we're going to be pulling that tibia anteriorly. So you ready? It's going to be here, 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 okay? So I'm pulling anterior. Okay. One thing that you might note is that I have really small hands, right? They're super small. And so for this patient who's petite, it works to kind of grab the leg and do a Lachman's. But on my 300-pound lineman, it was almost impossible to try to hold their quadricep, right? Which felt like 80 pounds. So in the clinical setting, what I would do in football is actually put my knee underneath the popliteal fossa to create that 20 to 30 degrees of knee flexion for me. And then I would just stabilize here, foot still in external rotation, and now I'm able to just do the Lachman's, right? Without having to worry about holding that leg up. So this is a clinical tip for those of us who will have small hands, okay? What's a positive Lachman's test? So a positive Lachman's test would be increased anterior translation or increased laxity anteriorly, right? The tibia is allowed to move too far anteriorly, then we know that ACL isn't doing its job, which is to do what, you guys? It's to prevent anterior translation of the tibia. So that will conclude our instability test. Those are tests for one ligament. We haven't talked about what happens if we have multiple ligaments involved. So we have the medial instability test for the MCL, which is a valgus stress test. We have the lateral instability test for the lateral collateral ligament. We have the posterior instability test for the posterior cruciate ligament, and we have the anterior instability test for the anterior cruciate ligament. These are all unilateral. These are all one ligamentous stress test. Our next group of special tests are going to be in the area of the iliotibial band, which is a lateral structure here, right? Remember we talked about that. It comes down distally and it has that attachment to the tubercle of Gertie or Gertie's tubercle, depending on who you have. We have two tests that we most often do to kind of test whether or not the iliotibial band is inflamed. One of those tests is the Noble's test, and then the other test is the Renee's test. One is a test where the patient is lying on the table. So you're going to have to excuse me because I'm going to do the one that comes second in your packet first because our patient is already lying down on the table, and that is the Noble's test. So with the Noble's test, a few things have to happen. Your patient has to be in a supine position, and you have to remember anatomical landmarks, okay? So the first anatomical landmark that we are going to focus on is going to be on the lateral side of the knee. And it's just so great that we can actually see the iliotibial band of our patient because this is telling me this is where I need to be with my hand placement. So distal hand or hand closest to the foot is going to grab the patient's foot. And then hand closest to the head is literally going to grip that IT band. I'm going to apply pressure. So I'm applying a pressure and I'm holding that pressure. The next thing that we want to do is actually flex and extend that leg from about 20 to 30 degrees of knee flexion. And what you're going to ask that patient is, do they have any pain while you're applying that pressure? Now you guys probably can't see that very well with this video, but I am applying a pressure that stays. I'm not letting up. As I flex and extend that, I'm maintaining that pressure. And what we know about the IT band is that as it moves from about 20 to 30 degrees of knee flexion, right, into 0 degrees of extension, it's crossing over the epicondyle. So that's where most of your patients with an iliotibial band syndrome are gonna have pain. So that's why we're doing that. So get them in about 20 to 30 degrees of knee flexion, apply that pressure and extend. What they will complain of is a sharp pain about the IT band or on the lateral aspect of the knee. Now we have RINS or René's test, which is a functional test and is important, right? When a patient's lying on a table, not very functional, but if our patient walks into us and is functional, then we want to test the IT band in a functional setting. So give us a few minutes to get set up for this patient. In this particular patient, they're going to stand, right? The ideal would be they'll stand on the floor, but for the purposes of this video, we're going to have the patient stand on the table so that we can capture it and allow you to see how it's done. So with René's, the patient is going to be in a standing position. Now remember, key things to keep in mind. The patient's in a standing position, first and foremost, on the floor, okay? It is completely unsafe to do this on a table. So I just want to be very clear. And so what we're going to do is, as a clinician, we're going to reposition ourselves just a little bit, okay? I'm going to stand in the front of my patient. Does that make sense, guys? I'm standing in front of my patient. And it's going to be a similar hand position, right? The difference is now we're testing the function of the IT band when the patient is standing. So what I'm going to do is use my thumb most often, but for this particular video purpose, I will use my index finger so you can truly see how it's supposed to be thumbed. Keeping in mind that you should be using your thumb when you're doing this special test. So again, I want to be directly over that IT band. I want to apply a pressure. What I'm going to have my patient do is squat to about 20 to 30 degrees, okay? Look at pressure, come back up. Do you have any pain? Go back down, okay? Come back up. One more time. Here, come back up. And so what's the goal of this test? What's the goal of this test with this particular patient? The goal of this test is to see whether or not there's exacerbation of the signs and symptoms in a non-functional position, which would be Noble's test, and whether or not there's pain with the functional test, which is the René's test, right? Both of them require you to put pressure on the IT band and to have either the patient flex or extend from a 20 to 30 degree knee angle, or to flex and extend that patient's knee for them. If you're asking me what I do in the clinical setting, if a patient is functional, I never do Noble's, right? Because if they're functional, there's no need to test in a non-functional position. I'll go right back down into René's and have them start in a standing position. So I'm giving you both tests because you might need to use one or the other, but choose based on your patient's functional level and ability. And that concludes anterior instability and iliotibial band syndrome tests. So we just finished anterior knee instability tests, and so right now what we're going to do are the iliotibial band tests. These are tests you're going to use to rule in or rule out a patient who potentially has iliotibial band syndrome. We are going to start with the most functional special test first, and then I'll show you a special test that you can use to rule in IT band syndrome in the event that your patient can't stand. So if they can only do a non-weight bearing task, I'll show you that test as well. But my preference is going to be the functional IT band test first. So with the patient in a standing position, what you're going to have the patient do is stand with their feet shoulder width apart. And once their feet are shoulder width apart, the next task that you're going to do is try to find the lateral epicondyle. You guys remember from lecture class that the IT band will snap over that lateral condyle and epicondyle. So it becomes important that you actually have your finger or your thumb over that lateral epicondyle and condyle when they are performing this movement task. So with the patient in a standing position, you're going to do the following things. With the hand that's closest to the leg that you are testing, you are either going to take your index finger or your thumb, and you're going to apply pressure around the condyle or epicondyle region. Now, with that said, if you're having difficulty locating that epicondyle, then just go ahead and flex the knee until you can actually find it. And you'll feel the tendon of the IT band as you're performing this exam. So once you've located where you're going to apply pressure with your thumb, you're gonna have that patient start in an extended position, and you're going to apply a pressure to that IT band. Now, one thing to note is that if the patient just has pain with your finger in this position, then maybe you should consider not even having them do the second component to this exam. If they are pain-free, then the next step in this exam is with pressure applied to the knee joint, you want to have that patient go into a squat position. So go ahead and squat for me. And how does that feel? Any pain?
No.
A positive Renee's test would be one in which the patient experiences pain at the IT band when they are going into a squat position. If they have no pain, then that is a negative Renee's test, and most likely that patient doesn't have iliotibial band syndrome. What we are going to do now is move into a less functional position using a less functional test. And this special test is known as the Noble's test. So in this position, your patient is going to lay on the table in a supine position. Patient, go ahead and have a seat. And then go ahead and lay down with your head facing this way. Good. And then on your back. So with Noble's test, the patient is in a supine position, and most often you would test the side that you are standing on. But for this video's example, we are going to test the side opposite us so that you can really truly get a good gauge of what I'm doing to perform this exam. So just like with the Renee's test, where you flexed and you had the patient extend, you're going to do something similarly. So with the hand that's most proximal to the head, you are going to place that thumb in the same position that you did for Renee's test. And with the hand closest to the foot, you're going to basically cup just right over the talocrural joint. So with my hand in this position, I am going to flex and extend that knee, looking for pain at the iliotibial band, just like we did in Renee's. So you all can see that these two tests are very similar. The major difference is the functionality of the test. As clinicians, you should always do or perform the most functional special test first. And then if your patient can't perform that movement task, then we move them into a less functional position. That will conclude special tests for the iliotibial band. So now we are progressing into the meniscal tests of the course. As we talked about in the online lectures, the meniscus are cartilaginous structures that prevent rubbing of the tibia and the femur proximally against one another. They are also shock absorbers, and they're key for joint nutrition of the tibial femoral joint. What we also know about the meniscus is that they are often injured in most knee injuries, so it becomes vitally important for you guys to understand how to assess them. With that said, there are over 15 to 20 different meniscal tests. So I am giving you the top 6 or 7 special tests that you should put in your toolbox and use as a clinician or an athletic trainer. The first special test that I'm going to give you is a very functional meniscal test. It's going to begin with the patient in a standing position, and this special test is known as the Thessaly's test. Thessaly's test is one of the most sensitive and specific special tests. So what's that mean? It's really good at ruling in and ruling out meniscal pathologies. In fact, it's been reported that it's about 90% likely that if this test is positive, then your patient probably has a meniscal injury. So with Thessaly's test, the patient's going to be standing, and of course not standing on a table, but standing on the floor. And what we are going to do is have the patient do rotary movements throughout this particular test. So with the patient in about 5 degrees of knee flexion on the injured side, you're going to have them lift the non-injured limb. And what they're going to do on this injured limb at 5 degrees of flexion is rotate both inward and outward. And you're going to ask your patient, do they have any pain? If they say no, then you're going to have them flex their knee to 20 degrees. And they're going to do the same rotary motions. And the big deal with this test is that you have to make sure they are rotating fully inward and fully outward, right? Because if we take them to extremes amounts of rotation, then what we'll see is that the femur will rub across that meniscus and elicit or generate pain. So that is the Thessaly's test. Now, some less functional special tests, which are certainly still capable of assessing a meniscal injury, are what we're getting ready to dive into next. And so the next special test that we are going to do is the Steinman's test. For the Steinman's test, your patient is going to be lying in a supine position. So I'm going to have my patient lie down in a supine position on her back. And once she's in a lying position, it is always best to perform the test on the same side of the patient that you are on. But in this particular instance, for recording purposes and for educational purposes, we're going to test on the side opposite me for today. But in class, you better be testing the same side that you are on, and that's all for ergonomic perspective, right? We want to save your back from leaning over across your patient, and so then it leads to less low back injury. So our next special test is the Steinman special test, and the purpose of the Steinman special test is to do what the Thistles did in a standing position, but now we're taking it and we're doing it in a non-functional position. So what am I saying, guys? If the Thistles test, or if standing or weight bearing causes pain, then we certainly shouldn't have our patient perform special tests in a weight bearing mechanism, right? We should have them non-weight bearing to just figure out what the pathology is. So with Steinman's test, the patient is in a supine position. What we are going to do is take a position that was similar to Noble's test. So distal hand is going to grip the ankle joint, and then proximal hand is going to be used to assist you in flexing the patient's knee. Now, one key component to the actual hip itself is that you want to make sure that the hip is at about a 45-degree angle. From here, the purpose of this test is to move the knee in and out of flexion while rotating the foot. So let me show you what that looks like. I'm going to cup the plantar surface of her foot with my hand, and I'm going to externally rotate the foot, and then I'm going to internally rotate the foot at that knee flex position. I am then going to flex the knee just a tad bit more. I'm going to externally rotate the foot, and then I'm going to internally rotate the foot and ask that patient while I'm doing that if they have any pain. If the answer is no, I'm going to progress her more into knee flexion moment, and I'm going to do the same thing. Into external rotation, into internal rotation, is there any pain? Now, I did that for slow-mo for educational purposes, but the reality is that test is actually relatively quick. So I'm going to flex the hip to about 45 degrees, the knee, and I'm just going to move that knee into flexion while externally and internally rotating that foot. If the exam is positive, then the patient will tell us one of two things. Either we will feel crepitus in the knee joint itself, or they could just report pain when you externally and internally rotate the tibia. Moving on to other special tests. The next special test is the McMurray special test. It is a special test that most physicians use, that most athletic trainers use, but would it surprise you to know that it is the least sensitive and least specific special test on the market? So what am I saying? You guys are all taking evidence-based practice right now, which means you know that a poorly sensitive or a poorly specific test is relatively bad for ruling in or diagnosing an injury. So I'm going to show it because the reality is you'll be tested on it, but it isn't a test that you should use in the clinical setting to rule in and rule out. The McMurray's test is a movement test that is an extension of the Steinman's test. So with the McMurray's test, the patient is in a supine position. The difference with McMurray's test is that you're going to take the patient's hip to about 90 degrees. See that there? The patient's knee is going to be at 90 degrees, right? And we are going to perform two different movement tasks with this special test. The first movement task is going to require you to externally rotate the tibia. So that foot should go in an external rotation moment. The second component to that test is that you are going to apply a valgus load on the knee, right? So we have two different stations. We have external rotation of the foot. We have a valgus load being applied to the knee. And then the third motion is to move that knee into an extended position. So here we go. If the patient has pain with that motion, I'll do it again, external rotation, valgus load. If the patient has pain with this motion, then most likely they have a medial meniscus tear. So let's talk about lateral meniscus and how we would test that. We would still start with the hip at 90 degrees, the knee at 90 degrees, but there are two subtle differences. The first one is the foot is now going to go into an internal rotation moment, and we are now going to be applying a varus load to the knee. Still taking that knee into extension, And if they report pain with this movement task, then we know that the lateral meniscus is injured. So just for review, if I'm doing medial meniscus, I externally rotate, valgus load applied, and I extend the knee. If there's pain, we're suspecting medial meniscus. If I think it's lateral meniscus, I internally rotate my foot and I apply a varus load to the knee. And if they have pain, then we are suspecting a lateral meniscus. So continuing on with meniscal special test, the next test that we have is the pinch test. The pinch test is performed with the patient in a supine position. So if you have a theme, what are you seeing? That I did all of my standing tests first, and now I've moved to a position where the patient is still continuing to stay in a supine position. So as a clinician, one of the great things about knowing what's going on in terms of testing is making sure that we're not making our patient flip over, turn around, stand up, right? Because then our patients start to lose confidence in us. So I hope you're seeing that as we progress through this special testing program. So the pinch test is done with the patient in a supine position, as you can see here. What you're going to do, what the clinician is going to do, is they're going to, with the distal hand, use it to cup the ankle joint. And with the proximal hand, what they're going to do is support the popliteal fossa of the knee. So again, they're going to support the popliteal fossa of the knee. You're going to take the thumb of that proximal hand and you're going to place it in the joint line of the meniscus you suspect is injured. Let me say that again. You're going to place it in the joint line of the meniscus that you suspect is injured, right? Once you have a good feel for where the joint line is, you're going to take the distal hand and you're going to flex the knee and extend the knee while applying pressure in the joint line. And it becomes important to take that knee all the way down into extension when you're doing that. So again, you're going to flex the knee, you're going to bring it down, you're going to extend the knee. And we're going to do that bilaterally always, right? Remember that every assessment that we do, every special test that we do, we always want to do it on the non or uninjured limb first. So what are the signs and symptoms, or what's considered to be a positive pinch test anytime they have pain in the joint line with that particular pressure? Now, our next special test, and really only meniscal special test where the patient is actually going to be in a prone position, is the Apley compression and distraction test. So in this special test, the patient is actually going to be on their stomach. So at this point in time in your special testing process, you're going to ask your patient to go ahead and roll over on their stomach. Once they've rolled over on their stomach, you have to make sure that you understand that the sides have swapped, right? This is now my patient's right side and my patient's left side, which means if this is the injured side that I've been testing this entire time, I have to make sure that this is the limb that I am testing. So with Apley's compression and distraction, essentially what we end up doing is flexing the knee to 90 degrees. So we are going to move that knee from an extended position to a flexed position, right? And in this test, what we are going to do are two different movement tasks. The first task is to apply pressure, hence the name Apley's compression. We are going to apply that downward pressure to the calcaneus, right? So we're going to apply a downward pressure, and while we're applying that downward pressure, what we are then going to do is externally rotate and internally rotate the tibia. While we're doing that, what we're going to ask our patient is, do they have pain, right? So as we compress, right, and rotate externally, rotate internally, we are asking that patient if they have pain. I'll show you on the opposite limb just for an even better view. So there's a compression moment that happens, internally rotating, externally rotating. Now you might have noticed in Steinman's test that we moved in and out of knee flexion. We literally stay static at 90 degrees of knee flexion with the compression component of Apley's, right? So what's next? Because I said Apley's compression and distraction, right? Well, if the patient has pain with the compression component, we then flex the knee back up to 90 degrees. And the difference with compression and distraction is in the name, distraction, to pull the joint apart. So I'm going to take both hands and right at mid Achilles and right on the talus, what I'm going to do is lift the knee joint up while providing a little bit of a distraction. And my question to my patient isn't going to be if there's pain, it's actually going to be, do you feel better, right? Because if we do this and we're distracting that joint, then we've removed the femur from the tibia, right? And so there's less contact on the meniscus, which means they should have reduced pain. The final special test is a functional special test. And it is the final meniscal special test that I'm going to show you because it's the last meniscal test that you should do when you are testing a patient who you suspect has a meniscus. Now, I've showed you 6 or 7 special tests. If 3 of them are positive, do you think you need to do the other 3 or 4? The answer is no, right? But let me show you the duck walk. The duck walk is a fully functional special test. So if you thought Thessaly's was functional, this tops that. So what we're going to do is have the patient in a standing position, and the instruction to the patient is going to be to squat down so low that your butt touches your heels. So patient, go ahead and squat down. And so from here, your patient's in a squat position, and what you're going to instruct your patient to do is slowly stay in that squat position and walk towards you. So that patient's going to walk in that squat position. Perfect patient. Do you have any pain with that? So if a patient has pain in the duck walk position, then we know that they have a meniscal injury, right? And we can think about anatomically what that means. So anatomically, what does that mean? If they're in that deep squat position, what we know without a doubt is that the femur and tibia are in its most maximal posterior position, so they are compressing those menisci. So if this doesn't hurt, they probably don't have a meniscus. Again, it is the last special test we do because it will exacerbate the signs and symptoms. This concludes the meniscal special test for this segment. So now we are moving into multi-directional instability tests. The first group of tests that we're going to talk about are anterior multi-directional instability. So we did a lot of ACL tests. So those were unilateral, one single ligamentous tests. And now what we're saying is, what happens if we have an athlete come in who's had an ACL, meniscus, and MCL injury? How do we test all of those without having to go through 30 different special tests? So these are multi-directional instability tests aimed at testing for ACL involvement. The first special test that we're going to talk about is a functional test with the patient standing. It's called the crossover test. The crossover test is done by having the patient do the following. So when you're with your patient in a standing position, the involved leg is going to be the leg that stays on the ground. The uninvolved leg is going to do what is called a crossover technique, and we are going to have that patient cross over in the front. When you do this, you need to make sure that that uninvolved limb crosses over the midline, as we see with this patient in the video. If the patient crosses over with the uninvolved leg in front and there is instability, this is a positive sign for anterior lateral instability. If the patient, however, comes back to a neutral position and crosses behind the uninvolved limb and complains of stability or collapses, then this is indicative of anterior medial instability, right? And so what do I mean by anterior lateral instability or anterior medial instability? If they have an anterior lateral instability, what that means is the ACL is involved, the lateral meniscus is involved, and the LCL is involved. If they have an anterior medial instability, what that means is the ACL is involved, the medial meniscus is involved, and the medial collateral ligament is involved. That again is the crossover test. So we just performed the crossover test, which was a fully functional test that was aimed at assessing multi-directional instability involving the anterior cruciate ligament. Now what we're going to do is perform some less functional tasks, because what we know about ACL ruptures is that they cause grave instability about the knee. So it may very well be that your patient just can't perform a crossover test. So in that event, we're going to lay the patient down on the table and we're going to perform 3 other types of special tests which are very good at ascertaining whether or not they have multiple ligamentous structures involved in their anterior knee injury. The first special test that we're going to talk about is the Slocum test. The Slocum test involves the patient laying in a supine position with the hip flexed to about 45 degrees and the knee placed in a 90-degree angle. Once the knee is placed in a 90-degree angle, we're going to do something different than we did with the anterior drawer. Remember, in the anterior drawer, the foot was in a straight forward position. In the Slocum test, the major difference is that you will rotate the foot either into internal rotation or external rotation. And this movement will help us determine which structures are being tested. So for the first component of Slocum, we are going to internally rotate the foot. We want to do so in a way that the patient's foot is still maintaining contact with the table. With the foot internally rotated, just like we did in the anterior drawer test, you are going to sit on that patient's foot. When you sit on that patient's foot, it provides stability for what you're getting ready to do next. With both of your hands, you're going to place them on the head of each gastroc. You're going to just lie your thumb on the tibial plateau. From here, we are going to do an anterior glide of the tibia. This is a very slow glide, not a fast one, not a jerky one, but a very slow glide. I like to equate that to pulling your drawer out of your your drawer out of your dresser when you're trying to grab something, right? It's a slow pull. If we pull the drawer out of the dresser too fast, what's going to happen? It's going to come off the tracks and maybe fall onto the floor. So think of the Slocum test that way. We're going to put our hands behind the gastrocs, thumb on the tibial plateau. We're going to glide that tibia anteriorly. Now, with the foot in an internal rotation moment, with an anterior glide, what we are assessing is anterior lateral instability. In other words, we're testing the ACL, we're testing the LCL, and we're testing the lateral meniscus for involvement. Now, let's say we suspect an anterior medial instability. Take the foot from a neutral position and externally rotate that foot. Same thing applies. I'm going to sit, and now we're going to pull the tibia in an anterior direction, right? And if this is positive for pain or for laxity, then we suspect the ACL, the MCL, and potentially the medial meniscus. That concludes the Slocum test. So the next set of special tests are what I call brother-sister special tests. You do one and then you do the other. So the first component or piece to this test is what's called the pivot shift test. And it is the last ACL test that I would ever do on earth. So in terms of patient evaluation, you're going to start very subtle with non-functional tests. You're going to move to functional tests. And then last but not least are what we call the pivot shift and the jerk test. And here's why. Not the jerk because I'm a jerk, but that's the name of the test. So here's why, you guys. It's because it's going to cause a subluxation of the tibia. And once you cause a subluxation of the tibia, what do you think? Your patient's not going to want to let you do any other test. So do not do the pivot shift test first. Do it last in your sequence of special testing for multi-directional instability, in particular on the anterior aspect of the knee. So for the pivot shift test, the patient is going to be in a supine position. And a few things are extremely important about this test. The first thing is your distal hand, or the hand closest to the foot, is going to cup the calcaneus. In addition to that, you're going to load that calcaneus. I hope you guys are tracking here. There is a load that is applied. It isn't just like I'm cupping the calcaneus. No, you have to load that calcaneus. You have to internally rotate that foot while loading the calcaneus, okay? The second and key component is that you have to apply a valgus load to the knee at the same time. So there are 3 key components. Number 1, I have to load the calcaneus. Number 2, I have to internally rotate the tibia. Number 3, I have to apply a valgus load. And then we have to push the knee up into flexion. So here we go. Load, internally rotate, valgus. As you are moving up into that knee flex position, what you will feel is a clunk and a shift, and your patient will feel it as well. Because if the ACL is intact, you shouldn't feel that clunk. You shouldn't feel that shifting of the tibia. But what happens with the Slocum is that because we've internally rotated and loaded, that tibia is now shifted, and so you're gonna feel that shift, right? So now that we're in this position, the next test is the jerk test. So with the patient in 90 degrees of hip flexion and 90 degrees of knee flexion, we're going to keep the same position. So we're going to load the calcaneus, we're going to internally rotate the foot, we're going to apply a valgus load, and we're going to bring them back down into a knee extended position to reposition the tibia, right? We've subluxed it, now we need to bring it back to its resting position. So again, let's just repeat this. Slocum starts here. Load the calcaneus. Internally rotate. Valgus force. Oh, clunk. Well, we should probably put them back, right? So they like us again. So then on the way back down, it's a valgus load, internal rotation, and we bring them down, and you should feel a clunk as they move back into a resting position. This again is for multi-directional instability. In particular, is for anterior medial rotary instability. That concludes all of the anterior medial and lateral rotary instabilities for the ACL. So we just finished the multi-directional anterior instability special test. Now we're segueing into the posterior instability multi-directional special test. So what's that mean? These are tests that involve the posterior cruciate ligament and the meniscus and or the LCL and or MCL. So the first special test that we are going to use is what is called the dial test. The dial test is done with the patient in a prone position, as you can see here, with their feet hanging off of the table. So if you had to ask me like to estimate how much they should be hanging off, about 4 finger widths from the talocrural joint would be where their foot should be hanging. From here, what we're going to do is position the patient's knees in 2 different angles. The first angle is going to be 30 degrees of knee flexion. So at 30 degrees of knee flexion, what you want to do is you want to grip, right, the midfoot on each side. You guys see that? My fingers are right in the medial longitudinal arch. My thumb is right at that lateral malleolus. What we're going to do from here is what the name implies. It's a dial test. You guys remember those old school phones where you would dial, literally dial the number? Well, it's similar, right? What we're going to do is externally rotate the feet until we hit an in block, right? I'm not stopping. Her hamstrings are stopping me. You guys see that? So once we get to this position, what we want to do is compare how much external rotation the patient has on the injured side versus the uninjured side, right? And if that difference is 10 degrees greater on the injured side, then we suspect they probably have what is called a posterior lateral corner injury, which means they've gotten all of the muscles, ligaments, and tendons that supply the posterior lateral corner of the knee. And you guys should all be pros on the posterior lateral corner of the knee because we've talked about it in lecture class. So then if we want to isolate just the PCL, what we're going to do is change the knee position such that the knee is now at 90 degrees, right? And in this position, I usually change my hand positioning as well. So my hand positioning is going to be here. We're going to do the same thing that we did at 30 degrees, which is externally rotate. What we want to do is compare how much external rotation we get at 90 degrees of knee flexion, just like we did at 30 degrees. The difference is if the patient has a positive side-by-side difference of 10 degrees on the injured side, then we're suspecting PCL injury, posterior cruciate lateral ligament injury, right? Let me say that again, posterior cruciate ligament injury, right? So let's repeat. At 30 degrees, if they have greater than 10 degrees side-by-side difference of external rotation, then we're suspecting the posterior lateral corner. At 90 degrees, if we externally rotate and there's more external rotation on the injured side, we are suspecting the posterior cruciate ligament. If they have positive 10 degrees difference at 30 degrees and positive 10 degrees difference at 90 degrees, then we are thinking that they probably have both a posterior lateral corner injury and a posterior cruciate ligament injury. So that is the dial test. We will now move into the external rotation recurvatum tests. And so in this particular patient, we're going to have this patient roll over into a supine position. With the patient in a supine position, as the name implies, external rotation recurvatum test. So with the patient in a supine position, with you literally taking the big toes or the first ray of that toe, what you're going to do is literally lift that patient's leg off the ground. Now, a positive finding would be increased hyperextension of the knee. Remember, the role of the PCL is to prevent posterior translation of the tibia. So if we grip the big toe, like here, right? And we let gravity do its work, what we would typically see is in a positive external recurvatum test, that tibia will drop posteriorly, right? So that would be a positive posterior external recurvatum test. So we just finished the dial test and the external recurvatum test, all tests used to test multi-directional instability posteriorly. The final test that we're going to use is the equivalent of Slocum's test for anterior rotary instability. It's called Houston's jaw. And just like with our Slocum's test, what we're going to do is something very similar. The patient is going to be in a supine position with the hip flexed to about 45, 50 degrees of flexion, but the big key component is the knee being flexed to 90 degrees. Now, normally with a posterior jaw for unilateral instability, we would have just pushed posteriorly on that tibia. But if we truly want to get at posterior multi-directional instability, we have to use a rotary component. So for this particular special test, if the goal is to rule in posterior medial instability, we want to make sure that the foot is in an internal rotation moment, okay? So this is for posterior medial instability. That means you're testing the PCL, MCL as a result. So what we're going to do is internally rotate that foot. And then what we're going to do is sit on that foot just like we did with Slocum for the posterior jaw, for the anterior jaw. The difference is that our push is going to be from the anterior tibia. So our hands are going to be on the anterior tibia and we're going to push posteriorly, right? We want to make sure that glide or that push is slow and controlled. And what we're looking for is increased posterior glide and or laxity. Again, with the foot in internal rotation, the Houston's jaw is testing for posterior medial instability. So that would be your MCL, your PCL, even your posterior oblique ligament. And then if we want to test for posterior lateral instability, what we're going to do is reposition the foot, but ensure that it's in an external rotation moment, right? With the foot in an external rotation moment, we're going to sit on it and we're going to do the same thing we did, push posteriorly. The difference is you'll see an increased posterior glide on the lateral side. And this would be indicative of a PCL injury, an LCL injury, coupled with potentially a lateral meniscus injury. So that concludes all of the special tests for the knee segment of the course. I really do hope all of these special tests have been helpful in allowing you to practice before we come into the lab. I look forward to seeing you all in class.